Welcome to Enhancing Diagnosis and Access to Treatment in EoE, What You Need to Know from Your Patients, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America, or AAFA, at immunologylive.com. My name is Dr. Mirna Shihadi, Professor of Pediatrics and Medicine and Founding Director of the Mount Sinai Center for Eosinophilic Disorders at the Icahn School of Medicine at Mount Sinai. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. Now, I'd like to introduce my co-presenter, Dr. Kathy Peterson, Professor of Medicine at the University of Utah. Thank you, Kathy, for joining me today. Let's get started. Here are our disclosures. By the end of this session, we hope that you would be able to achieve the following learning objectives. Collect a thorough patient history, asking about symptoms and adaptive behaviors that may call for evaluation for eosinophilic esophagitis, or EoE. Summarize data related to biological therapy targeting type 2 inflammation to manage EoE in children, adolescents, and adults. And outline recent expert guidance on the place of biologic agents in the management of EoE to enhance patient quality of life, safety, and growth. Starting with EoE epidemiology, disease burden, and diagnosis. EoE can be defined as a chronic immune-mediated esophageal disease characterized by pathological eosinophilic inflammation of the esophagus and related esophageal symptoms. EoE is thought to be allergic in etiology, and the triggers for EoE with an allergic type 2 inflammation include food allergens, and at times in a subset of patients, environmental allergens as well. I am certain that many of you are seeing more EoE patients than in the past. This is partly because the incidence and prevalence of EoE have been increasing over time. To illustrate this, I'm referring you to a graph created by Drs. Dallon and Hirano, which shows the increasing prevalence of EoE over the years in many parts of the world. The current prevalence of EoE is estimated at 0.5 to 1 per 1,000 individuals. You may think that this number is too small, but then it becomes more impressive when you see that patients with EoE are seen more often within certain scenarios that you may encounter. So if we go over the demographics of these patients, EoE occurs most often in patients less than 50 years of age. EoE is 3 times more common in males than in females. It is found in 2 to 7% of patients undergoing endoscopy for any reason, but found in 12 to up to 23% of patients undergoing endoscopy for dysphagia. In fact, it is the most common cause of esophageal food impaction. EoE is more common in patients with food allergies and or atopy, and by atopy we mean asthma, allergic rhinitis, and or atopic dermatitis. In a recent cross-sectional survey conducted by the Asthma and Allergy Foundation of America, or AAFA, in collaboration with the American Partnership for Eosinophilic Disorders, or APFED, of patients with EoE and their caregivers across their memberships and social media channels, EoE was diagnosed among all age groups, as you could see on the slide, with the smallest percentage of patients diagnosed at 60 years of age or older. It is important to know that the clinical presentation of EoE varies across age groups. Infants or toddlers have very nonspecific symptoms, many of which are really centered around feeding. These symptoms can include gastroesophageal reflux symptoms, coughing or gagging with food, feeding difficulties, food refusal, and some of them can also have failure to thrive. Children also can present with general GI symptoms, including abdominal pain, vomiting, and at times failure to thrive. Some children, though, start presenting with very typical esophageal symptoms that are usually common for adolescents and adults, and these are dysphagia and food impaction. Adults and adolescents, most of these patients have esophageal-specific symptoms, and these are dysphagia and or food impaction. Many, though, can have substernal chest pain. Typically, this is the pain that is refractory to antacid treatment, and some of them can also have heartburn. So if we place data on children and adults on the same graph, just to get a better visual for these differences, we can see the following. Here, the blue bars represent adults and green bars represent children. As you could see in the blue bars representing the adults, most adults have dysphagia and or food impaction. But then as you could see with the green bars, most children have nonspecific GI symptoms, including abdominal pain and reflux symptoms, including vomiting. Up to a third of children with EoE can have failure to thrive, and luckily this is potentially reversible with adequate treatment for EoE. Now, to know whether the differences in symptoms between children and adults are intrinsic or simply a result of possible progression of symptoms over time, we conducted a few years ago a multi-center study that included 317 children, where we divided those children into 3 different age groups. Blue bars here represent the 0 to 2-year-olds, green bars represent the 3 to 10-year-olds, and the black bars represent the 11 to 17-year-old patients. So what we noticed is that as we were dealing with older and older patients, we were seeing less and less of the vomiting, growth failure, and food refusal, which are the less specific symptoms, and more of the esophageal, typical esophageal symptoms, including dysphagia, food impaction, and heartburn. In all age groups, it is important to keep in mind, both for children as well as adults with EoE, patients follow compensatory feeding behaviors in order to reduce the severity of their dysphagia and to prevent food impactions. These include prolonged chewing, drinking with every bite of food, cutting food into very small pieces, lubricating tough or lumpy foods with condiments or dunking them in liquids, and even in severe cases, avoidance of tough textured foods altogether. One way to remember all of this is to use the IMPACT acronym. So I is for imbibe fluids with meals, M, modify food, and that's by cutting it into small pieces or pureeing it, P, prolonged meal times, A, avoid hard texture foods, C, chew excessively, and T, turn away tablets or pills. So the conclusion from this that it's important that you obtain a history on feeding patterns of patients suspected to have EoE, in addition to asking them for dysphagia, and the IMPACT acronym is good to have handy in those cases. Now let's listen to Allison, who talks about her symptoms and compensatory behaviors.
So most of my life, I've cut food really small, and I would never eat food without having water or a drink with me. I always use sauces and things, but I didn't know why. It didn't seem abnormal to me. I just thought that I ate. That's just how I ate. And I always took longer, but I thought, well, that's just me. So I didn't really think of anything about it. I didn't have an actual impaction though until we had been in the Midwest about 5 years. And I didn't know what it was. I just had trouble swallowing. It was uncomfortable, but it passed. And as time went on, these impactions got worse. Again, I didn't know what it was. I didn't know why I couldn't swallow. It became more and more embarrassing. I was on a girls' trip and I took one bite of meat and ended up in a full-blown impaction that lasted about an hour, and it was mortifying. Eating in public became really scary because I didn't understand what was causing impactions. So I didn't really want to go out and be social. Or if I did, I would eat very small amounts of food because I didn't want to risk anything.
Great story from Allison illustrating what patients go through. Now we have a polling question for you. How confident are you in your ability to diagnose EoE? A, not at all confident. B, not very confident. C, confident. D, very confident. And E, extremely confident. The poll starts now. So Kathy, as our audience is filling out the poll questions, and before we get the answers here, what do you think of this question? What do you think of your ability to diagnose EoE?
Myrna, I think all of us have gotten much better at it, but it's been a learning curve, don't you think? I remember years ago, doing endoscopies and not recognizing what I was seeing. And now it's way better, but we've all been extremely lucky that we've had all this education and we are getting better, which is fantastic. I don't know how you feel, but I feel like I've gotten much better at knowing when to look for it.
I fully agree. I think this was a steep learning curve that we had to go through, and now we are very confident. I think the more you see the patients, the more you invest time in this, the more and more you get confident in diagnosing it. And there's always a whole community of EoE docs that are ready to answer questions, us included. So we do have the answer here for the polling question, and the most common answer I could see is B, which is not very confident. So this is really important to know, and I'm so glad we're having this educational session, as a confidence in diagnosis of EoE is of paramount importance, as a delay in diagnosing EoE has been often observed, and that could have complications. So here we refer you to, again, the survey that was done by the AFA in collaboration with APFED, where patients and caregivers of patients with EoE were asked about how long to get an EoE diagnosis from the time symptoms were first noticed. And as you could see, the results were all over the place, reaching up to 10 plus years with some patients. More recently, in an informal poll of patients or caregivers seeking to learn about EoE in an earlier patient education program, which is linked to this one, the time gap also was high, with most patients reporting a diagnostic delay of more than 1 year. So how do we diagnose EoE? According to the newest diagnostic algorithm, if you have a clinical presentation suggestive of EoE, and the patient undergoes an upper endoscopy with biopsies demonstrating esophageal eosinophilia, as evidenced by finding 15 or more eosinophils per high power field, the next step is to evaluate for non-EoE disorders that cause or may contribute to esophageal eosinophilia. And if none are there, then the diagnosis is indeed EoE. Long gone are the recommendations of trying a PPI therapy first before you diagnose EoE. PPI is no longer a requirement now as a diagnostic tool, but it is used as a treatment option for EoE in the right patient. So what do we see on endoscopy? One or more features of EoE can be seen. One could see furrows or white exudates, or even white exudates lining up along the furrows. And these are what we refer to as the inflammatory features. These features are seen both in children and in adults. When the inflammation has gone for a long period of time, now we start getting the chance of seeing the fibrous stenotic features of EoE. And these are more often seen in adults as a result. These include rings and or strictures. Now, it's important to keep in mind that the esophagus appears normal in up to 20% of patients with EoE, especially in the pediatric population, highlighting the need to obtain multiple biopsies so that the diagnosis is not missed. So what do we see on biopsies? On your left is a section of a biopsy from an individual with a healthy esophagus, and normally you should have 0 eosinophils in the esophageal mucosa. On the right is a section of a biopsy from a patient with EoE, and you could see all the eosinophils infiltrating the esophageal mucosa. Histologically, finding 15 or more eosinophils per high-power field satisfies the histological criterion for EoE. Eosinophils like to shape in various patterns in the mucosa. So on your left, you could see the eosinophilic superficial layering and formation of microabscesses. And this is what corresponds to the white exudates that we just shown on endoscopy. Eosinophils can also degranulate, as you could see on the right side of your slide. Now, it's important to keep in mind that EoE is a patchy disease. Therefore, it is important to obtain a minimum of 6 biopsies so that the diagnosis is not missed. And it's good to target various parts of the esophagus, typically the distal and proximal esophagus, or variations thereof. What are the non-EoE causes of esophageal eosinophilia? There are multiple, and it's important to think about one or more of these depending on the patient's history in front of you. And a few that are important to highlight include gastroesophageal reflux disease, other eosinophilic GI diseases such as eosinophilic gastritis or eosinophilic duodenitis with esophageal involvement, celiac disease, Crohn's disease, hypereosinophilic syndrome, drug hypersensitivity, and connective tissue disease. The burden of EoE is high, both for patients as well as their caregivers, and it encompasses several domains. From a symptom perspective, patients do carry a large burden. For example, the burden of dysphagia and food impactions and the burden of GI symptoms. Patients with EoE also carry the burden of comorbidities, whether atopic or non-atopic comorbidities, as well as that of complications. Examples include the need for esophageal dilations and failure to thrive in children. Burden can also be psychosocial, and that includes anxiety and or depression, as well as disruptions in daily life and social activities. And let's not forget the financial burden, and that includes the high cost of diagnosis, the need for repeat visits and endoscopies, and the indirect costs of this, including special diets, missed work, and missed school days. So if we look at the comorbidities that tend to be overlooked at times, and if we look at specifically the allergic comorbidities in EoE, this is the result from a multi-center study that we conducted a few years ago that included 705 children and adults with EoE. As you could see, many of the patients had one or more allergic comorbidity, including allergic conjunctivitis, allergic rhinitis, asthma, atopic dermatitis, food allergy, and drug anaphylaxis. If we look again at the survey that was conducted by the AAFA in collaboration with ABFED, the results confirm these findings when it comes to atopic comorbidities. But as you can see on the slide, there are many non-atopic comorbidities as well, including anxiety and or depression, irritable bowel syndrome, and autoimmune conditions. Therefore, as soon as EoE is diagnosed, given its burden and its potential complications, timely treatment is important. The overall goals of EoE therapy include relieving symptoms, eliminating esophageal eosinophilic inflammation, improving quality of life, and preventing complications. So what are the treatments available? One possible treatment option for patients with EoE is dietary restriction therapy. Since we know that EoE is caused by food triggers, 3 types of diet have been extensively described and published and have therefore become standard of care. The first one is the elemental diet, where patients remove all the foods that they're consuming and are placed exclusively on an amino acid-based formula, which is hypoallergenic. And as you can see, the remission rate is really high. However, the quality of life really suffers with these types of treatment. Then there is the test-directed elimination diet, where the foods that test positive by skin prick test and or A2P patch test are removed. And this diet has not performed well either in children or adults. And then we have the empiric 6-food elimination diet, where common food allergens are empirically removed from a patient's diet, and these include milk, wheat, egg, soy, nuts, and seafood. And this has done relatively well in terms of the histological remission rate and overall efficacy. However, removing 6 food groups is still significant burden on patients with EoE. Therefore, other less restrictive elimination diets have been recently tested, including the 4-food elimination diet, consisting of removal of milk, wheat, egg, and soy, the 2-food elimination diet, where milk and wheat are removed from the diet, and the 1-food elimination diet, where only milk is removed from the diet. Now, when we say milk, we mean milk and all milk products, just to clarify that. If we plot all of the different diets on the same curve so that we can look at the comparative efficacy of the diets used for EoE. So if we walk through that graph from the bottom all the way up, on the x-axis is efficacy rate in percent, you could see that the most effective is the elemental diet, followed by the series of empiric elimination diets. That's 6-food, then 4-food, then 2-food elimination diet. This is followed by the allergy test-directed elimination diet, and finally, the 1-food elimination diet or milk elimination. Dietary restriction therapies are not for every patient with EoE, however. There are multiple factors to consider before you suggest or before you place your patient on a dietary restriction therapy. These include age, the diet or the nutritional status of the patient. Therefore, it's important to examine for malnutrition, feeding difficulties, self-restrictive behavior toward food, and the numbers of foods that the patient is already avoiding before they got diagnosed with EoE. Social and financial factors are important to consider, including the motivation of the patient and their family, and to examine whether there is a good social and financial support system to sustain these diets in these patients. And finally, acceptance of multiple endoscopies to really hone down which foods are the food triggers in these patients is important. Related to dietary therapies, an interesting and important allergy phenomenon to keep in mind is this potential bidirectional progression between food-induced IgE-mediated allergy and food-induced EoE. To illustrate this, I'm referring you to 2 papers as examples, one by Magadotir and colleagues, where they reported 17 children who outgrew their IgE-mediated food allergy, who then developed EoE triggered by the same food. At our center, we reported 5 patients who avoided food to manage EoE that later on developed an IgE-mediated hypersensitivity to that same food that was removed. So important to keep in mind from this is that periodic allergy testing to foods that are removed is advised here due to the risk of a de novo IgE-mediated allergic reactivity after prolonged avoidance of that food for EoE. So what if diet does not work for a patient with EoE or is not effective for that patient? Then pharmacological therapy is the answer. And there are many options for these patients from that standpoint. The first option is the proton pump inhibitor or PPI. And as you can see here from a systematic review conducted by Lucendo and colleagues, the efficacy rate is around 50%, both in children as well as adults. Topical corticosteroids, even though none are yet FDA approved for EoE, they are commonly used as a treatment option for these patients and have become standard of care. These include fluticasone HFA inhaler to swallow instead of inhaling, and budesonide to swallow, rendered viscous so it's thick and it coats the esophagus, using a sugar substitute or maple syrup, for example. And the efficacy rate based on 8 randomized controlled trials using these drugs is around 65%. Now, there are multi-center trials using steroids that were tested over the past few years. And here I'm listing a few for your information. One is using the budesonide oral suspension. This was a phase 3 trial, final results of which are included here. The trial included 318 patients, 11 to 55 years of age. They were randomized 2-to-1 to receive budesonide 2 milligrams twice a day versus placebo. And after 12 weeks of treatment, the percentage of patients that achieved clinical response was significantly higher in those that received budesonide compared to placebo. And histologically, the proportion of patients that achieved histological response was much higher in the budesonide-treated group compared to placebo. An open-label extension up to 52 weeks demonstrated that efficacy was maintained among the initial responders. Unfortunately, the FDA did not end up approving this medication. Another medication that was tested so far is the fluticasone dissolvable tablets, or APT-1011. This was a multicenter double-blind placebo-controlled phase 1b/2a trial. This was a small study, included 24 EoE patients, both adolescents and adults. They were randomized to receive the drug at 3 milligrams once daily, or 1.5 milligrams twice a day, or placebo. And after 8 weeks of treatment, clinical improvement as measured by patient global assessment was higher in the fluticasone-treated group compared to placebo, and histological remission was also higher in the fluticasone-treated group compared to placebo. A phase 3 trial is currently ongoing using 3 milligrams once daily of the drug versus placebo. So we'll have to stay tuned for the results of that trial. A third topical steroid worth mentioning is the budesonide oral dispersible tablet. This was a multicenter double-blind placebo-controlled phase 3 trial that included adults with EoE, 93 EoE patients, 18 to 75 years of age. They were randomized to receive 1 milligrams twice a day of budesonide or placebo. And after 6 weeks of treatment, the percentage of patients in clinical histological remission at week 6 was significantly higher in the budesonide-treated group compared to placebo. And this has led the European Medicines Agency, or AMA, to approve the drug in Europe. There is no approval by the FDA for this drug, as the study was conducted exclusively in the European Union. Now I'd like to give the stage to my colleague, Dr. Peterson, who will discuss targeted agents for EoE management in children and adults. Kathy?
Great. Thank you, Mirna. Thanks everybody for joining today. I get to be the lucky one to talk about targeted agents. And so to start this conversation, I think it's important to talk about the inflammatory pathway of EoE. It's not just a one-step pathway. The thought that right now that we have is that patients are predisposed, that they have an allergic predisposal, they get some sort of environmental exposure and have maybe a genetic susceptibility, as we do see this run in families. And then they get an antigenic exposure. Often, as Mirna showed you, through dietary trials and dietary elimination, people get better. So food is definitely one of the common triggers. Other things can trigger as well, we think, in some patients. But what happens is you get this antigenic exposure, you have this setup to develop this allergic T2 phenomenon, and then this exposure to your esophagus sets off these alarmins, TSLP, IL-33, and that recruits in inflammatory cells. So T cells get recruited in, they secrete cytokines like IL-4, IL-13. Those contribute to dilated intracellular spaces. So it's basically taking that nice barrier of your esophagus and disrupting that barrier. They recruit in other immune cells and start this huge inflammatory cascade. Other contributions occur when eotaxin 3 is secreted that helps recruit in eosinophils. So there are multiple cells involved in the disease and then multiple inflammatory pathways. And that kind of sets us up from different drug options or different medication options to start trying to block that. So as you can see from this graph, biologics such as dupilumab and cendakimab are going to try to hit that IL-4 and 13 cross-section. Proton pump inhibitors work not only just by reducing acid, but actually reducing the expression of eotaxin 3. There are other biologics such as lirentelimab and benralizumab that have been studied, and I'll go over that really briefly, in actually just inhibiting eosinophils in general, since that seems to be the cell that everybody has focused on in this disease. Dupilumab is FDA approved now for the treatment of EoE, and it works not just by inhibiting IL-4, it inhibits both the mechanism of IL-4 and IL-13 by blocking this alpha chain, so that it actually inhibits their ability to actually work on the type 1 and the type 2 receptors, which are involved in multiple different cells. So dupilumab is unique that way that it actually inhibits this signaling from two different T2 cytokines or allergic cytokines through their receptors to kind of inhibit that kind of cascade of allergic or atopic kind of events in inflammatory disease. Dupilumab is FDA approved for EoE in patients older than 12, as long as the weight is greater than 40 kilograms. But it's also FDA approved for some of these comorbidities that we see in EoE. So moderate to severe atopic dermatitis in patients greater than 6 years old, moderate to severe asthma in patients greater than 6 years old, and then in adults in chronic rhinosinusitis with nasal polyposis or prurigo nodularis. So it already has some FDA approved indications in addition to also being approved for EoE. I just want to go over really quickly the phase 2 study results of dupilumab, which have led to it being approved, FDA approved for EoE. The initial phase 2, and then I'll go over phase 3 results, actually were about a 3-month study where they looked at administering dupilumab weekly to patients, 300 milligrams a week injection versus placebo in a series of EoE patients. And what they found that you can see on this graph that I'm showing you on the far left is that symptoms were dramatically reduced by week 10. But also not even just symptoms. We'll go over how we assess responses in EoE, but eosinophil infiltration was reduced dramatically and statistically significantly. And what we look at from a GI perspective, the actual endoscopic signs of EoE, so the rings that Mirna showed you, the furrows, the edema, they all improved at 3 months on weekly injections of dupilumab compared to placebo. This was an exciting phase 2 study. So then they went on to a phase 3 study design. And this is a little more complicated. And this was done in adults and adolescents. So what they did initially for part A is they said, okay, well, it worked every week. So we're now going to compare dupilumab every week to placebo every week and have everybody blinded. And we'll do that for 6 months. We'll do 24 weeks of this. And then if people respond to the dupilumab, they'll continue on an open label. So part C was continuing on for a year-long trial in dupilumab. And if they were on placebo initially, then would move to part C, which again, they would automatically get weekly dupilumab. Part B, the way they designed the trials, they wanted to look at the difference between every other week, because that's how dupilumab is prescribed for like asthma, to weekly dupilumab to placebo. So part B did a 3 kind of point comparison. They did that for 24 weeks. And then if you were on placebo, you were either randomized to weekly or every other week. And then if you weren't on placebo, you stayed on your initial dosing out to 52 weeks. And these are the results. So if you look on the left-hand side, this is the week 24 result here. And the week 24 result here is that dupilumab, if you look at the percentage of patients that had histologic response, so that is response at of less than 6 eosinophils as mandated by the FDA, then 60% of patients on the weekly dose had actually histologic response at week 24. And if you look on the right-hand side of this far left graph, if I can explain that well, even if you're on every other week, you had dramatic response at week 24 at this point. Very similar between every other week and weekly. If you look over on the right-hand side, this is where everybody moved into that 52-week period. And what they showed is that you had a dramatic improvement in your symptoms. But also if you went on weekly dupilumab, that improvement, if you went from placebo to dupilumab out to 52 weeks, patients still, they improved their symptoms. So dupilumab, when patients were initially on placebo, then moved over to the actual weekly injection, their symptoms improved at 52 weeks. And that would kind of explain this. This graph explains why FDA approved weekly dupilumab. So if you look at the dysphagia symptom questionnaire, What the difference was is even though every other week dupilumab resulted in histologic improvement, endoscopic improvement, the actual symptom improvement was very clear when you graphed out weekly versus every other week dupilumab in patients. And so you can see the difference here in this graph where the symptom score improved dramatically in patients when they were receiving weekly dosing versus every other week, excuse me. And then if you look again, quality of life improves. So if you look at the eosinophilic esophagitis impact questionnaire or the symptom questionnaire, again, dramatic improvement in dupilumab versus placebo in all of these different measurements that were done in the phase 3 trial. Anytime that a drug gets approved, the first question should always be for our patients, like, what is the safety of this drug? And so these are the safety profiles that were documented throughout the study and all the adverse events. And what you can kind of see if you look very closely at this in Part A, Part B, and Part C, where they took the drug out to the 52-week mark, is that the safety profile is pretty comparable to placebo. So that there weren't really a large amount of safety findings. You know, people reported maybe headaches or nasopharyngitis, but not really significantly more than that also was reported in placebo. And there are some reported injection site reactions, but again, if you look at the total group, not necessarily a lot different than placebo. So it looks at this point, based on these initial safety findings, that dupilumab has a relatively good safety profile. So this has been approved 12 years and older. Now the question is, will this drug, if indicated, work in young children? And actually our host today was kind of the lead presenter on the study that was done recently, and actually recently the results shown in children. So they actually took dupilumab and studied that at weight-based doses for children. And they looked at 103 children and they went out to about 16 weeks. And at 16 weeks, they showed that even about both dupilumab doses showed significant difference in histologic disease remission at that 16-week mark. And that children who were on the higher dose had about an 86% reduction in the peak eosinophils per high power field from their baseline, compared to only 21% on placebo. And then again, a large reduction in how the disease, the severity and the extent compared to placebo. So that looks like at this point, based on this trial, that this drug will be studied further in children to look at its efficacy in young children as well. So now we're going to go back to Allison and we're going to have her explain what her experience was when she went on a biologic for her eosinophilic esophagitis.
I'm on a biologic. I'm in full remission. That means I can take all of my medications, including my allergy medications, which are large pills that I couldn't take before. I can sit down and have a full dinner with my family and not worry about having an impaction. Or I can go out to dinner with friends and not be thinking about, am I going to have to run to the bathroom and embarrass myself or have a very public situation that alerts everybody in the restaurant. I no longer have to think about any of that, which is such a relief just to be a normal human. And most days I don't even think about having EoE.
So it's wonderful to hear how Allison has improved on when she started taking a biologic therapy for her disease. And that leads us into all of these other novel potential therapeutics for EoE that have been studied. So there have been phase 2-3 trials in larentilimab and benralizumab, and those were the drugs that I discussed actually eradicate in one way or another eosinophilia. But what we found, based on the preliminary trial results that have been published now or presented at meetings nationally, is that even though we can eradicate the eosinophils, the symptoms did not get better. And that brings back to that initial kind of graph and figure that I showed you, that EoE is probably multifactorial. There's multiple different immune cells involved in the disease. And even though we call it eosinophilic esophagitis, it does appear that we need to maybe try to look at it as larger than just an eosinophil disease, that depleting eosinophils is not necessarily going to get us where we need to be on histologic or symptomatic remission. Other drugs, though, are now coming out. There is etrasimide, and that is a cousin of maybe what people are aware of, ozanimide, which has been approved for ulcerative colitis. And this is a sphingosine 1 phosphate receptor modulator. And they just completed a phase 2 trial in EoE. There have been case reports in vedolizumab, which is an alpha-4 beta-7 integrin antibody. There is a phase 2-3 trial coming out, or currently, I think, enrolling for tezepelumab, and that is, as we talked about, those initial alarmins with the TSLP. That's a drug that actually tries to inhibit that TSLP signaling, so that initial signaling from the epithelium. We'll talk a little bit about cendakimab, as that's now finished with a phase 2 trial and moving on to phase 3 and currently recruiting in their phase 3 trial. And then there's an unusual medication called, they don't have an actual name yet, 1104 or 1805. That is this immune resetting agent that I'll present some preliminary data on. And the one drug I can't pronounce, which is an anti-KIT monoclonal antibody mast cell inhibitor that is now in phase 2 and also recruiting. So multiple different angles and aspects, and so a lot of potential options in the future for patients with EoE. I'm going to talk really quickly about cendakimab, as they had their phase 2 trial completed. And this is a little bit different than dupilumab. This is actually a recombinant humanized monoclonal antibody that's actually selective for IL-13. So it hits IL-13 and inhibits its ability to actually act on its receptors, the first receptor, which both dupilumab works on, and then the second receptor, the alpha-2 receptor. The phase 2 clinical trial results were encouraging. If you looked at the left-hand side of this graph, and this is where they randomized patients for 16 weeks, and they did adults, and they looked at 180 or 360 milligrams versus placebo, and this was an injection weekly. And at 16 weeks, what they showed is that there was improvement, if you look at the blue graph and the green graph, on both the lower and the higher doses of cendakimab, where there really wasn't an improvement in placebo. And again, with the endoscopic scores, what we look at, what Mirna's shown you, with the inflammatory exudates, the rings, the furrows, the edema, again, it showed that cendakimab resulted in both dosing, actually an improvement in the endoscopies on all of the patients. Interestingly, again, very similar, in a similar fashion, the higher dose, although both of these were delivered weekly, the higher dose is what really showed the difference in dysphagia scores. And this was borderline significant. It was a p.07 in the overall population, but very significant if you looked at the steroid refractory subpopulation of this phase 2 trial. So it's demonstrating that maybe these higher doses might be somehow doing something different to allow for this change of symptom score. Because remember, these patients and the clinicians are all blinded during this study. This is a synthetic peptide. So this is a synthetic peptide that is 1104, which was recently studied, and they just reported some new results. So this is a peptide that tends to reset the immune system and not allow it to develop such large immune responses in patients. And this is what EoE is. It is kind of immune response to an external stimulus. And so what they showed in an 8-week trial, they reported out in April of this year that they actually reached their primary endpoint, that they decreased esophageal intraepithelial eosinophils, and that they had other histologic improvement. And they showed that it was had a pretty good favorable safety and tolerability profile. And then in July, just now, they came out and said, well, actually, not only that, patients improved their symptoms, that it actually seems that it has a mechanistic effect on all of those cells that we talked about involved in eosinophilic disease. And so that potentially this is another therapy that will be moving on into a phase 3 trial and not an injection, or no, I think it is an injection, infusion at that time. Okay, so at this point, I think what we're going to move into is we're going to move into some a scenario just to kind of think about how we want to integrate everything we've learned so far today and everything that we're continuing to learn, both Mira and I learn on a daily basis. And want to talk about integrating these new treatment options into clinical practice. So just things to think about. And I wanted to start really quickly with a patient case and then use that to kind of go through the guidelines. So imagine having a 12-year-old boy who had significant EoE. He comes to you, it all started at 9 years old. It started out on budesonide. You know, we know that that's off-label therapy, but started on 1 milligram twice a day, failed that histologically and with symptoms, went on high-dose PPI, failed that. So finally, we end up putting him on a 2-food elimination diet, milk and dairy. And he did improve. If you look at those lower endoscopies, it went from 120 eosinophils per high power field, see all those exudates, the furrows, the edema, and went down to 30 with some patchy disease throughout, but really, was doing okay, but not able to sustain his growth. He was falling off the growth chart. He just wasn't feeling well. So you start him on a 6-food elimination diet. You now take out the wheat, the dairy, the soy, the egg, the seafood, the peanuts, and the tree nuts. And he comes back in. And maybe, you scope him again. Everything looks amazing. His weight's stable, but he's still not gaining weight. So he's dropped off the growth chart. He's below the 50th percentile. He's not actually getting anything back. You do this for a while, and he's still complaining that he's not feeling well. So what are your options? Like, what can you do in these cases with EoE? And the AGA has kind of tried, the American Gastroenterology Association has tried to actually develop some guidelines to help us think about cases like this, like where we go and how do we approach these patients. One thing that has been developed is kind of a flow chart. Say, okay, we have eosinophilic esophagitis. Do we put them on dietary therapy or medical therapy? First decision. If it's medical therapy, do we do proton pump inhibition or topical steroids? And if you have a non-response or response, you can switch over to the other arm. If they have a relevant, like an adult esophageal stricture, they can get symptomatic relief, although you're not curing the disease by doing a dilation. And then both of these scenarios, if you get better, then you'll go on maintenance therapy. But now that we have dupilumab, we have to start thinking about where do we put this in the entire kind of look and this flow chart of figuring out where we want our patients to go. Where do we go with this new FDA approved therapy? Well, a lot of the leaders in allergy and asthma and immunology, as well as gastroenterology, got together and tried to develop a guidance on this to try to say, what do we want to consider with our FDA approved not first line therapy, dupilumab? Do we want to actually use it as step-up therapy, make patients fail, and then move into dupilumab, or do we want to use it actually as first line? And the thought is you may want to look at it differently according to your type of patient. So if you have multiple comorbid conditions, including these atopic conditions that we know that dupilumab is approved for, that you could consider as a first-line therapy. But they also said you can consider it a step-up therapy. If you have somebody not doing well on an elimination diet, or you're worried about avoidant restrictive food intake disorder, if you have failure to thrive, if they aren't tolerating any other therapies or need to use lots of rescue therapies, meaning dilations, even though they look like they're doing okay on a topical steroid, or if you're worried about adverse events, if they're getting side effects from any of these other therapies, these are times to consider moving up into a biologic as a step-up therapy. It does require shared decision-making. It requires a conversation with the children, with the parents, or with the patient, if the patient is an adult patient, to have these pro and con conversations with them about options for therapy. Okay, well, at this point, we are going to do a poll, and I want you to rate what your confidence is in appropriately prescribing dupilumab for patients with EoE. And A is not at all confident, B, not very confident, C, confident, D, very confident, or E, extremely confident. And we'll open up now for the poll for everybody. And Myrna, how do you feel about this? Dupilumab just got approved about over a year ago. How do you feel like your confidence is increasing in prescribing this?
Yes, indeed. I have been having a steep increase in building my confidence prescribing it. I do admit, we were part of the trials for EoE. And so we got to really experience this medication firsthand during the trial. But now that we're prescribing it since May 2022, now we're dealing with the real world scenarios. And so for efficacy, what I'm trying to do is use the yardstick guidance, and more than that, really get shared decision-making with the patient and discuss with them. Patients many have heard of the medication, and they're eager to discuss it with us. So this has created a lot of different scenarios that we may or may not consider. And so we're learning from that. In terms of safety, As a gastroenterologist or pediatric gastroenterologist treating both kids and adults with EoE, I have not prescribed it before. However, we're so blessed by having a community of allergists, pulmonologists, dermatologists who have been using this medication for other indications, and they have been helping me a lot in terms of sharing their experiences related to safety. So yes, I would say at the beginning it's a little hard, and then it improves as time goes on, and more prescriptions are done, and patients always give that constant feedback.
That's great. I think you bring up a really good point, which is we are so lucky that we work in this field where we have this ability of our allergy immunology colleagues to bounce things off of, which really helps us get much more comfortable in prescribing this. I think at this point we can go over the polling results. So let's go through this. Let's see. Well, this is the polling results at this point, where we have polling results that were done prior with patients and caregivers. And that before this activity, when we did an activity, I think Myrna may have actually done this activity where they looked and they wanted to know how comfortable are patients and caregivers with their knowledge about biologics for EoE. And what we realize is that actually over 50% of these patients and caregivers of patients don't really feel very knowledgeable at all about biologics. So it really is important for us to kind of have that shared decision making, as Myrna brings up, to have that conversation with our patients so that we can educate them and come to a really nice, well-educated decision on how we want to approach therapy in our patients. All right, so I will move in here and we'll move into our monitoring. So if and when we decide that we want to treat patients with EoE, I think what's really important for everybody to understand is that it's more than just following symptoms, that we've realized over several years and over several probably mistakes that we've all made in the last 20 years. I think Myrna and I both agree that we've probably made some mistakes in trying to handle EoE patients, that it actually is a triad, that we have to look at not just how the patients are feeling, but we have to look at biopsy results and what their endoscopy looks like, because it's now been shown that symptoms don't correlate really well with disease activity. So we want to know if they're feeling better, do they actually look better? Because they may be feeling better, but they could have active disease that will then bring them back with these food impactions or strictures later on down the road. So it's very important to make sure that we follow up with endoscopy, with clinic visits for symptoms, but then also biopsies, and make sure that these biopsies are done so that we can accurately assess the disease. And what's been really nice is actually Evan Dellin came up with a couple of other experts in the field, and they looked at this framework. We know that sometimes in these diseases, and it's very similar to inflammatory bowel disease, that not everything can be black and white. So really what we want to do is we want to look at the spectrum. We want to look like, is their histology better? Are their symptoms better? And do they feel like they've had complete, or are they close to complete normalization on endoscopy? So like, you want to look at where the non-response is to complete resolution, and look at, do you have less than 15 eosinophils per high power field, or do you have more? Do you feel like their endoscopy went from completely involved to less involved? And these are actually speaks to having a nice relationship with both the allergist, immunologist, and the gastroenterologist to have these conversations to accurately assess how well your patients are doing. Because it's great in every world if we have complete normalization, but sometimes getting 90% better is really all we need. And so we can assess this based on this kind of guideline that they're giving us, looking for biopsy, endoscopy, and symptoms in these patients. And with that, I'm going to move on and hand this back to Myrna to do the question and answer session. Thank you for listening.
Thank you, Kathy. So Kathy and I will be answering your questions. Thank you so much for placing so many questions. So we're going to try to address some of them right now. I think one quick one is about related to dietary restriction therapy. So when you eliminate milk from a patient's diet, does that mean all milk products, including whey ingredients and milk baked into foods, such as in a breaded coating, for example? So, Cassie, would you like to answer that?
Sure. So it's a great question. And honestly, yes. So that initially you, and Myrna, you can tell me, this is honestly an art, but initially I think the way most of us do this, we remove everything out of the diet. We're extremely strict. If a patient responds to that, then you can have this conversation. There is some literature out there. I think Dr. Leong actually published some literature where adding in maybe baked milk is a potential in the future for some patients. And there are some ongoing trials, very interesting ongoing trials with like ultra pasteurized milk. But the initial elimination, you want to know if just anything involved with dairy products is causing the issue. So you take everything out. And that speaks to a really nice relationship as well with a nutritionist so that you can have that burden kind of taken off your shoulders, or the patient can. I don't know how you feel, Myrna, but that's how I feel about it. So.
Oh, absolutely. I do agree with you, Cassie. When you are avoiding milk or restricting milk for a patient with EoE initially, you want to remove all of them just so you can have a clear-cut decision about whether this is a trigger or not. And, you know, an interesting thing is about whey. I'm glad that you asked that question. Yeah. The audience asked that. Since I see this often in teenagers and young adults with EoE. So they have dysphagia that has been going on for a while and left undiagnosed until they decide to join a gym and they start taking supplements. And that's when the first food impaction happens. This is not necessarily a specific thing. It's just that now we are doing a dairy consumption that is 10 times more what they would have done otherwise, because whey protein is just now you're dealing with a concentrated, a pure form of a milk protein. And so it's really important, the lesson from this, it's important to ask about whey supplements and other supplements that your patients are taking, since I've noticed this is not always something that clinicians may think about asking.
Mm-hmm. That's a great point.
So we move to 2 more questions here. We have time for that. I think there's a really question that I'd like you to address here, Dr. Peterson, which is how important is endoscopy for EoE? We do have many doctors right now in the audience and providers who are in the allergy immunology field or other fields than gastroenterology. And I think it would be important to address the importance of an endoscopy specifically in the management of patients with EoE.
Yeah, no, that's a really good question. I think, you know, that the last few slides really spoke to that too. It's hard. And so with allergy immunology, you want to have a good relationship with a gastroenterologist because the data is really out there. We cannot trust symptoms to really know what's going on. Patients, as you mentioned, I mean, patients adapt. They adapt to their symptoms, and especially by children are very nonspecific, and then by adults, they've adapted so that they don't actually know, you know, if they're having problems sometimes because they've already learned that they chew everything, they drink everything with a lot of water, they use the condiments to take it down. So endoscopy is really important, along with those biopsies that you mentioned, at least a minimum of 6 biopsies to demonstrate whether the disease is better or not.
Great point, Kathy. I think it's also important to keep in mind that patients with EoE could have other esophageal comorbidities. Especially in the adult population, you could have concurrent gastroesophageal reflux with erosions and ulcers that could explain some of their symptoms. And in some patients, reflux could be secondary to the inflammation from EoE or concurrent and independent of EoE. So it's really important to take a look and know what's going on. And as you mentioned, I think you were right on the mark here, is that it's good to see if you are putting a patient on a specific treatment to know what's happening to that esophagus, since symptoms are not perfect to track response to treatment, given all these accommodations that patients follow. The other thing is that I'd like to add here, and I don't know if that's your experience, Kathy, here, is that if a patient has a stricture and we give them a treatment that removes inflammation, sometimes we really cannot know whether that it worked to reduce the inflammation because of the persistent dysphagia from a stricture. So, excuse me. Sometimes it's important to sorry about that, it's cold seasons. It's important to do an endoscopy and biopsies to really know whether that treatment is effective at reducing the inflammation or not. I hope you agree with that. Any thoughts on this, Kathy?
No, I mean, I think it's important that we follow up with the endoscopy for sure, that we also know. I mean, the other thing when we do topical steroids and sometimes even, PPI, sometimes when somebody has dysphagia, like you mentioned, I think it's very important is, we didn't talk about this, but there can be like Candida esophagitis, and and that has been reported. So we want to know what's going on even with symptoms. Is it active disease or is it something else and a side effect of the medication that we've given them?
Great point. Thank you, Kathy. So I think in the interest of time, to respect everyone's time, we're going to close for questions. Of course, both Dr. Peterson and I are available for any questions via email if you have. Now, I'd like to close by thank you, Dr. Peterson, and thanks to our audience for all the great questions.
Thanks, Mirna.
I would like to also thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com to view today's session, along with other sessions on demand. My name is Mirna Shehadi. Thank you for joining us.